So good afternoon, everyone. Welcome to the CCCF Academy, and thank you very much for joining us today. My name is Patrick O'Neill. I'm a medical science liaison for bioMérieux Canada. Some of you may recognize our company name from when we co-located in our yearly AMR symposium with the CCCF annual conference in 2024. But for those of you who are unfamiliar with the name, bioMérieux is a French in vitro diagnostics company, and we make the instruments that microlabs in hospitals across Canada use for the diagnosis of infectious diseases. These technologies span the entire traditional microbiology workflow, including pathogen culturing, identification, and of course, antimicrobial susceptibility testing, since fighting antimicrobial resistance is a central mission for us at bioMérieux. We also offer multiplex PCR-based testing for infections affecting everything from the central nervous system to the bloodstream, as well as the respiratory tract, of course, which will be our focus for today. To that end, we have the luxury of hosting Dr. Arthur Jeng, who's a professor of clinical medicine at the UCLA School of Medicine and the chief of the Division of Infectious Diseases at the Allevue Medical Center of UCLA in California. Dr. Jeng received his medical degree and postgraduate medical trainings from the University of California, San Diego School of Medicine and joined the faculty at UCLA in 2003. He has more than 20 years of teaching experience and 25 years of clinical experience, specializing in infectious diseases, with special expertise in bacteriology, its resistance, and antibiotic usage. He's also the director of antibiotic stewardship at his institution. This afternoon, Dr. Jeng will be speaking to the role of multiplex PCR-based diagnostics and what they can do in the management for pneumonia. This presentation will provide an overview of the microbiology of different types of pneumonia, how clinical evidence supports the use of multiplex PCR to rapidly optimize antibiotic therapy, and he will provide real-life examples of cases where this technology was used to quickly manage pneumonia in the ICU. Dr. Jeng, thank you very much for being here, and the floor is yours.
Thank you so much. Thank you for the introduction, Patrick. So the lecture that I'll be talking about today is called The Management of Pneumonia in the Era of Rapid Multiplex PCR Diagnostics. And so we'll be talking, of course, about pneumonia and respiratory infections, which I think everybody in the audience sees on a daily basis almost. And pneumonia is just some background to start with, is the number one reason for hospital admissions in most countries for an infectious disease. Community-acquired pneumonia in the United States affects 4.5 million Americans annually on average, and is responsible for 1.5 million hospitalizations annually. Our Centers for Disease Control in 2021 has estimated that the mortality for pneumonia in the US was about 12.4 per 100,000 people and responsible for about a little bit over 41,000 deaths in year 21. And it's the number one cause of ICU admission and sepsis, and the number one cause of death from infection in the United States. When you take influenza and pneumonia together, it's about the sixth leading cause of death worldwide. This is all causes, including non-infectious etiologies. So pneumonia is just one of the most common infectious diseases that we see. Shown on the right-hand side in the pie graph here is a study about which infections are seen in the ICU most commonly. And this is a study done in Belgium, but pretty much all studies in the ICU show the same thing. In the blue part of the pie, you can see that's respiratory infections, including pneumonia. It's responsible for about half of the infections seen in the ICU in this survey. Intra-abdominal infections number 2, UTI-related infections number 3. And then almost all ICU-related infection surveys, this is kind of the rank order of which infections are most commonly seen, with pneumonia being number 1. With community-acquired pneumonia, which of course is acquired by the patient at home or out in the community, it's historically strep pneumonia was always the most common bacterial cause of community-acquired pneumonia, and that's still the case today. Historically, Haemophilus influenza is number 2 cause. However, this has gone down a lot since the worldwide administration of the HIV vaccine. There are some atypical bacteria that can also cause community-acquired pneumonia, including Mycoplasma, Chlamydophila, and of these 3, the most severe will be Legionella. Despite the usage of the conjugated strep pneumonia vaccine, and in the United States, we've been giving it to adults for many years, strep pneumonia is still the number 1 cause of community-acquired pneumonia in adults. And in studies that use very sophisticated methods in trying to determine the etiology up to almost 40% of the cases. Here's a study that was comparing antibiotic A from the first column and versus antibiotic B from the second column. And in these sort of antibiotic type trials, they do use a lot of methods to try and figure out what the cause of the pneumonia is. You can see that in this trial called the OPTIC trial, Strep pneumoniae was still the most commonly identified bacteria, despite, again, our usage of vaccines. With hospital-acquired pneumonia, which all of you know is when you get a pneumonia in the hospital, you don't come in the hospital with pneumonia, but you get in the hospital, you get the hospital, the pneumonia in the hospital after 48 hours. And VAP or ventilator-associated pneumonia means that you're intubated, don't have a pneumonia, but then after 48 hours, be on the ventilator, get a pneumonia. The VAP, HAP, these nosocomial pneumonias are the most common infections seen in ICU, and up to 22% of the infections in the United States in the ICU is due to these HAP, VAP settings. Compared to community-acquired pneumonia, the nosocomial pneumonias are associated with a higher mortality. Studies have shown HAP about 22%, VAP about 27% mortality. The microbiology of nosocomial pneumonia is also much more wide and varied compared to community-acquired pneumonia. In nosocomial pneumonia, the gram-positive bacteria isn't Strep pneumoniae so much anymore, but rather Staph aureus, and here we worry about MRSA depending on the hospital or nursing home type prevalence of MRSA in your community, but also gram-negatives. And so this is where we see gram-negatives such as Pseudomonas, other members of the Enterobacterialis like E. coli, Klebsiella, Enterobacter, Proteus, and Acinetobacter coming into play. Of the ones I listed, Acinetobacter and Pseudomonas are the ones that can become multi-drug or even pan-resistant to antibiotics, virtually pan-resistant. So it's much more difficult to guess what the cause of hospital-acquired or ventilator-associated pneumonia is. Historically, Pseudomonas was the number one gram-negative cause of HAP, VAP, although I think more recent trials have shown that Klebsiella has really jumped the ranks. And in this trial that was just done up through year 19, where they compared the antibiotic in the first column versus the antibiotic in the second column, Klebsiella just eked out Pseudomonas as the number one gram-negative cause of VAP. But Pseudomonas is a very close second. Acinetobacter was third. Viruses are also another cause of pneumonia, and I want to highlight this because although when we talk about pneumonia from infection, I think most people just kind of jump to bacteria as the main cause, but viruses are well known to cause pneumonia. I think in the post-COVID-19 era now, this is very widely appreciated, but prior to COVID, I think was not as well appreciated. Historically, influenza was identified as probably the most worrisome and most common cause of viral pneumonias, and responsible for probably more than half of the cases of viral pneumonias, again, pre-COVID-19. It can be, when using techniques to identify viruses, it can be responsible for 10 to 20% of community-acquired pneumonia outbreaks, and in epidemics, up to 50% or so of the cases. Other viruses, though, can also cause pneumonia besides influenza, including adenovirus, particularly serotype 14, parainfluenza, RSV, which I'll comment on a little bit in just a few bullets, and of course, coronavirus, which I think pre-COVID-19 wasn't as well recognized as a bad player, but obviously now everyone is very well aware of a SARS-CoV-2 causing pneumonia. With RSV, this is a virus that has always been around, and it's always been, I think, well appreciated to be a huge problem in neonates, but it is a big problem in the older adult population as well. So here on the right-hand side, I can show this is a study done at the Southern California Kaisers in the state where I live, and this study was ran through year 15, where they looked at the adults age 16 and over who had either influenza or RSV, and then kind of just tracked the characteristics and the outcomes. And what they found was that in these Kaiser patients with influenza or RSV, actually the survival for people with RSV was actually lower than that of influenza, shown in the yellow. And when you look at some other outcomes like length of stay, admission to ICU, mortality, all of these were worse than with RSV compared to influenza. So what this study was showing was that although I think our perception is that influenza is much worse than maybe RSV, objective studies don't really show that. Keep in mind, though, when we look at studies like this, though, that when the study was done, again, it ran through year 11 through 15, we do have a vaccine for influenza, which can attenuate or mitigate the symptoms and severity of influenza if you get it. And also, we do have a treatment for influenza in oseltamivir, where even to this day, we don't have a treatment for RSV. So that all you have to take all that into account when you look at these worst outcomes for RSV. Pneumonia. Viral pneumonias can be difficult to differentiate from bacteria in terms of initial symptomology and even on chest X-ray. Classically on chest CT is shown here. They have bilateral ground glass opacities and not so much the lobar air buccogram type consolidations that they see with bacterial pneumonia. Again, this whole ground glass opacities in the airfields was much more well appreciated when COVID-19 hit. I think everybody saw very good examples of that happening. When you get a virus, though, one of the more feared complications is that you can get a superinfection with the bacteria. I'm going to go into that in the subsequent slides. For this past influenza season, our Centers for Disease Control estimated that there were up to 54 million symptomatic cases, which was responsible for about 770,000 hospitalizations and associated with up to 78,000 deaths this past season. It's also known that with influenza, early treatment with the antiviral for influenza, oseltamivir, can save lives. Although we try to give the antiviral as early as possible, ideally within 48 hours of symptom onset. What the H1N1 pandemic in 2009 had shown us, though, was that even if you gave oseltamivir in very severe influenza pneumonia after 48 hours, so in this study done by my colleague Janice Louie from University of San Francisco, UCSF, she's found that even up to day 5 after symptom onset, there was a mortality benefit in giving oseltamivir. So what this says is that if you see somebody with severe influenza pneumonia and it's after 48 hours of symptom onset, oseltamivir should not be withheld even in that setting. Going to show a ICU case from the US that happened not too long ago. And this is a 29-year-old woman. She's got a history of lupus, mixed connective tissue disease, and scleroderma, and Raynaud's phenomenon. She's on a few medications that are immunosuppressive, mycophenolate, and prednisone, and hydroxychloroquine. She came in with fever and cough for about 6 days. She had related that her son was recently diagnosed with RSV. Despite having been offered vaccines, she had declined vaccines. When she came in, her temperature was 38.7. Her pulse was 130s. She was hypotensive at 87/47. Her blood test showed a white blood cell count of 2.6 with 31% bands. And otherwise, she was anemic and thrombocytopenic with a platelet count of 65,000. She was in renal failure, BUN 27, creatinine 2.24, and also having some liver failure. Additional blood testing showed that she was in DIC. Her nasopharyngeal RSV PCR is positive, and that's, I think, not maybe that surprising given that she had relayed that her son had been recently diagnosed with RSV. But within 12 hours, though, her blood cultures all grew strep pneumo. She actually went downhill very quickly. She was very quickly placed on 4 vasopressors. The entire duration of vasopressor use was 11 days. She developed purpura fulminans, as you can see here in the pictures, very well exemplified in the dorsum of the feet and the legs here. She also developed digital necrosis, and this was probably felt to be more from the prolonged vasopressor usage. And she was hospitalized for 2.5 months, actually. She did survive, although she did need amputations of the fingers and toes as well as the right foot seen here. What's interesting about this case was that she in total had 3 prior episodes of strep pneumobacteremia and pneumonia prior to this episode here, and 1 episode after this episode here of strep pneumonia and bacteremia. But in all of those cases, all of those prior and subsequent cases, her course was not complicated like this. Once she got antibiotics, even though she was initially hypotensive, once she got antibiotics, she'd actually recover very quickly. This was the only time where she had such a severe and prolonged course. The only difference amongst all of these 6 times that she got strep pneumo, sepsis, and invasive disease was the fact that in this case, she had RSV prior to that. So what we know is that there's this relationship between viruses and bacteria. When you get a virus first, and then you get a bacterial superinfection afterwards, it can portend a much more severe course. and presentation and disease. This was historically seen in the 1800s. They saw an increase in bacterial pneumonias after influenza pandemics, and in 1847, William Farr described this concept of excess mortality, increase in deaths that followed the influenza season. Dr. Collins had plotted this out, as you can see down here, based on the excess mortality after every influenza season. During the 1918 Spanish influenza pandemic, where there were up to 50 million deaths, autopsies showed that many of the patients had evidence of bacterial infections. This is just a histology of lung sections on some of the autopsy samples showing massive amounts of neutrophil infiltrations into the lungs. And microbiology done on these postmortem lung cultures have shown especially three bacteria that show up that can be cultured out of the lungs: Strep pneumo, what they call Strep hemolyticus back then, but it's actually group A strep or strep pyogenes now, and Staph aureus. These three bacteria, Diplococcus influenza is that one's H flu that showed up as well. Sorry, Bacillus influenza is H flu. That was also seen as well. But these three up here, Strep pneumo, group A strep, and Staph aureus, showed up particularly frequently in the postmortem lung tissue examinations. If you skip forward to the 09 H1N1 quote unquote swine flu pandemic, our CDC had published this alert where they found that when they surveyed the autopsy specimens of patients that died, about 30% of them had evidence of bacterial infections, most commonly with Strep pneumo, then Staph aureus, and then group A strep. So again, these three bacteria show up again as the most common causes of bacterial superinfections of viruses, in this case, H1N1 influenza. I think the drop in Haemophilus influenza by the H1N1 pandemic was due to the success of our HIV vaccine. So we don't see that particular bacteria so much anymore. So this is a phenomenon that we see even in epidemiological studies. You can see this. I show here a 4-hospital epidemiological study from Houston where they were using viral diagnostic studies and looking at the invasive pneumococcal cases. Invasive pneumococcal disease, by the way, means isolation of Strep pneumo from a sterile site in your body, most commonly blood. So in other words, the bacteremic with Strep pneumo. You can look at the months and when the viruses hit, parainfluenza, RSV, and influenza, and then the cases of bacteremia with Strep pneumo and sepsis basically follow that. Here's another survey from Tennessee through 02, again, a 4-hospital survey here, looking at over 4,000 invasive pneumococcal cases. You can see that the invasive pneumococcal disease cases peaked after influenza and RSV are circulating. RSV shown in red, influenza shown in blue, and then the invasive pneumococcal cases are shown in green here. Probably our best study from a hospital documenting or illustrating this relationship was done in France and shown in this publication here. This was a study done in Paris. It was done in the Bichot Club Bernard University Hospital, ran through year 2015. And in their ICU, they actually were using PCR to detect bacteria and viruses as a cause of the pneumonias in their ICU type setting. They also used standard cultures, and they kind of grouped their patients into having bacterial pneumonia by itself, viruses by itself, or mixed, meaning both viruses and then followed by bacteria. And here's some of the cases they didn't figure out etiology. But they compared the characteristics and clinical outcomes of each of these categories. And what they found was that if you had a mixed pneumonia, meaning a virus than a bacteria, you had a significantly more likely to have a quote unquote more complicated course. Complicated course in their definition was dying by mortality or needing to be on a mechanical ventilator for more than a week. So complicated course was seen in almost 70% of the cases of mixed viral bacterial pneumonia versus 39% in bacteria alone. The pneumonia severity index of 4 to 6 was higher in the mixed infections at 80 versus 67% in bacteria alone. And numerically, there was more vasopressor needs in the mixed infections, 60 versus 39% in bacteria alone. ARDS was seen more commonly in the mixed infections. And in-hospital mortality was also higher in the virus plus bacterial mixed infections compared to bacteria alone. And this has led a lot of laboratories to try and figure out why is the virus being on board and then bacteria subsequently portend such a worse outcome. In some, what these studies have basically shown is that the pathogenesis is that likely the viruses damage the airways in the lung tissue to expose receptors and proteins that weren't previously being exposed or um, and these receptors and proteins are what bacteria need to bind to and subsequently invade the lung tissue. And some of the studies have shown that some of these proteins that are exposed are, for example, platelet activating factor receptor from the inflammation. During the remodeling and regeneration phase after damage, additional types of proteins are expressed in abundance, including fibrin and fibrinogen. And it's well known that bacteria like to bind to fibrin and fibrinogen. Also, after viral infections, there's obstruction of small airways with disruption of surfactant, increased secretions, and in this sort of edema fluid and influx of inflammatory cells, it kind of creates a good medium for the bacteria to grow in. After a virus, there's also reduced ciliary function in the lungs, which of course impairs the clearance of bacteria. And it's also been shown by laboratories that viruses can alter the local immune response in the lung, which can increase the bacterial pathogenicity. I show here some in vitro studies in laboratories that are looking at this relationship. And in the first one here, they basically incubated viruses, either rhinovirus or RSV, in plates with respiratory epithelial cells for about 60 minutes. And then they added strep pneumo to these plates with respiratory epithelial cells. And in the white here, this is placebo, no virus is added. In the black is rhinovirus, and the crossed hatch is RSV. You can see that over time, there's significantly more increased binding of strep pneumo to the respiratory epithelial cells that had been pre-exposed to either virus, actually, either rhinovirus or RSV. And in this study, they seem to show that the protein that they seem to like to bind to was platelet activating factor receptor, or PAF-R. And another in vitro study, this is now done in mice. They had intranasal inoculation of the RSV virus into the mouse, and then followed by intranasal inoculation of strep pneumo. And you can see that the survival of the mice with strep pneumo alone was 100%. But when you added the RSV beforehand and then strep pneumo afterwards, actually had 100% death. In the lung tissue, when they homogenized it and tried to grow the bacteria, the growth of strep pneumo was significantly higher in the RSV pretreated groups of mice. And then lastly, in the condition score, this is the severity of disease, significantly higher, worse, in other words, with RSV plus strep pneumo. So in this study, they show that RSV pre-exposure to the mice significantly increased strep pneumo virulence. And what they're able to show is that there was upregulation in some of the virulence factors in strep pneumo, including pneumolysins and neuraminidase. It's important to recognize that when you see a viral pneumonia, that simple nasopharyngeal swabs may not necessarily rule it out or detect it. Early in the viral infections, the nasopharyngeal swab has a very high sensitivity and is very good. But later in the viral pneumonia, the nasopharyngeal PCR sensitivity is lower. Up to 20% of the nasopharyngeal samples can be negative in viral pneumonias. And this is where we need to get the sputum to then diagnose it. The lower respiratory samples will be positive, should be positive. This is nicely illustrated in this publication here. This is a publication from Japan in the Ishikawa Prefectural Central Hospital. This was a 47-year-old man who was presenting with fever, cough, and headache. He had gone into the outpatient setting to get seen, and he had serial nasopharyngeal influenza PCRs done over a period of 7 days, 3 times. All were negative. Finally, he got admitted. On the admission, the nasopharyngeal PCR was also negative. The pulmonologist did a bronchoscopy on him. His BAL PCR, influenza PCR, was positive. And after the PCR was positive, he actually got placed on an anti-influenza medicine, peramivir, which is the intravenous version of oseltamivir, and that's when he started getting better. And he had this diagnosis occurred after 7 days of symptoms. So a very good example where the lower respiratory sample will be positive, but the nasopharyngeal sample is negative. So it's important to check the sputum if you have a strong suspicion of viral pneumonia. I think everyone in the audience is well aware that in the ICU type setting, giving the appropriate antibiotics is particularly critical in that setting. And that's probably the most cited study is shown here in Kumar et al. This is a Canadian US study in ICUs ran through year '04, where they looked at patients after going to septic shock. Did they get the antibiotic that's covering the offending organism or not? And what they showed was that if you are in septic shock and you did not get an antibiotic that's covering the offending organism, for every hour of delay in getting that antibiotic, there is about a 7 to 12% decrease in survival, increase in death. And so this is why when sudden septic shock, it's urgent or more critical that we place the patient on the correct antibiotics. In this study, again, they showed that pneumonia was most commonly seen infection, followed by intra-abdominal infections, and then urosepsis is third. This kind of rank order is what I told you in the beginning, is what most studies have shown as the most common cause of ICU-related infections. And so this is what was, of course, led in the ICU type setting to use broad spectrum antibiotics, because in the beginning, we don't really know what's causing the infections. We've got to make sure we cover it, particularly when they're in septic shock. But I think it's important to underscore, though, that it's not really just a mere administration of broad spectrum antibiotics that's important for the survival of the patient, but rather it's the administration of the appropriate antibiotic to cover the infecting pathogen. But it's just that we don't know in the beginning what's causing the infection, which is why the broad spectrum drugs are given. The broad spectrum drug is not covering the offending pathogen. It's actually not going to be of much utility either, though. If you give a narrow spectrum antibiotic and it covers the offending pathogen, then that's going to be life-saving. So that concept, I think, is very important to point out. The challenge, though, with pneumonia, of course, is that a lot of times we don't get the pathogen causing pneumonia. In studies, over 60% of the cases of pneumonia, we don't figure out what's causing the pneumonia. And about only 14% of the cases are the bacteria actually cultured by conventional means. Additionally, when we do standard culture-based diagnoses, there's a growth time that needs to be done, right? Up to 40 to 72 hours before we figure out what's growing on the plate and what's causing the pneumonia by our standard identifications and susceptibility type testing. Also, the atypical bacteria that causes pneumonia cannot be cultured out, or I should say, it's very difficult to culture out. Most laboratories don't carry the means to culture out the atypical bacteria. Viruses may not be routinely tested in a non-pandemic or epidemic type setting, outbreak type setting. So that may initially be missed. We can use acute and convalescent serologies to diagnose non-culturable organisms like viruses and atypical bacteria, but this is going to be of very limited utility in the acute management of patients because convalescent serology is done usually 2 to 4 weeks after the infection is started, and that's usually an outpatient type setting. So not really helpful in the inpatient setting. For Legionella specifically, we do have a urine Legionella antigen, but keep in mind that the urine Legionella antigen detects one species, Legionella pneumophila, and of that species, only serogroup 1 and not the other serogroups. And it won't detect, of course, the other non-pneumophila species of Legionella. So the sensitivity is anywhere from 70 to 80%. If your lab does not perform this urine test, then it usually sends it out, and the turnaround time is going to be slower, of course, in that setting. When we look at our guidelines, the IDSA, Infectious Disease Society of America, shared with the American Thoracic Society guidelines on how to empirically treat communicable pneumonia, you can see a table like this. So here in the US anyways, we start with beta-lactam usually plus something that covers atypical like a macrolide or tetracycline, but then it gives all these following conditions. If there's recent isolation MRSA, then depending on whether the patient is severe or not severe, you can test for it or empirically treat for it. Same with Pseudomonas if there's a recent isolate. The big question is what's recent. That's kind of complicated about what's recent. People have different sort of thresholds for saying what's recent. What about if the patient has a recent hospitalization and then they got discharged recently, and do they have risks for MRSA or Pseudomonas? And again, how recent is recent for a recent hospitalization? How long is a long hospitalization? All of these are complexities that I think give a lot of our providers in the US kind of confusion, and it's not very clear in the guidance about what to do here. And a lot of assumptions have to be made. Similarly, for HAP and VAP, this is what the table looks like in our guidelines. The recommendation is to typically start with a gram-negative antibiotic that covers Pseudomonas, also adding an antibiotic that covers MRSA. Depending on the patient's very severe or not, you might give a second antibiotic that covers gram-negatives for which the first antibiotic may not cover if it's resistant to it. You might want to look at prior cultures again. Again, if are the prior cultures recent enough to be useful and predictive of what's causing the infection now? What time period do you use? If the patient's from a nursing home, that floor might be different than the hospital. So all these are the complexities that go along with trying to choose these empiric antibiotics for nosocomial pneumonia as well, and it can cause, again, a lot of difficulty in the antibiotic selection. On the flip side of things, as we use more antibiotics, as I think everybody in the audience knows, what we see is rising antibiotic resistance, particularly gram-negative bacteria. Gram-negative bacteria can become resistant to any and all antibiotics, including our new ones that have just been developed and released. And ESBLs is very common, I think, throughout the world. The CTXM gene is the one that's most prevalent across the world now. Carbapenem resistance is also prevalent across the world. It's depending on which country you live in, more or less prevalent. Here in the US, KPC is a very common gene that we see in the United States that causes, in the Enterobacterialis order, carbapenem resistance. But Pseudomonas and Acinetobacter both are well known to get resistant to carbapenems very, very easily due to intrinsic chromosomal mechanisms that they have. They don't need to acquire any of these resistances. And what we know is that the more antibiotics we use, the more resistance that we see. Here's a first study I show here from Germany, looking at the consumption of carbapenems with Pseudomonas resistance to carbapenems. You can see that they pretty much mirror each other. A similar study in Spain, looking at the carbapenem consumption with Acinetobacter resistant to carbapenems. Again, a very linear relationship. Here in the United States, this is the Northwestern Hospital, looking at the consumption of Erta, Emi, and Meropenem and the CRE rates at this US hospital. They all show the same thing. The more antibiotics we use, the more resistance that we see because of the selective pressure. And we also, the other downside of always using broad-spectrum antibiotics is, of course, C. diff, which is a worldwide problem. Shown here is a meta-analysis looking at the risk of C. diff based on different types of antibiotic classes. You can see actually certain antibiotics are more associated with giving C. diff, like clindamycin, for example, is probably the highest risk, followed by quinolones, then followed by broad-spectrum cephalosporins and carbapenems. And our Centers for Disease Control did a study as well. They're looking at the CDC Emerging Infection Program and the National Administrative Database. And what they found was that the relative risk of C. diff within 180 days after exposure to broad-spectrum antibiotics was about 3. But they estimated that a 30% reduction in exposure to broad-spectrum antibiotics could lead to almost the same amount of C. diff reduction. So in other words, although we need to use broad-spectrum antibiotics, I think minimizing the amount that we use can be beneficial. So that's what led our society, IDSA, as well as the WHO, to come out with plans on antibiotic stewardship and how we can more judiciously use antibiotics. The most common recommendation here is that when we figure out what's causing the infection, to then de-escalate. De-escalate means that we change the antibiotics or stop multiple antibiotics to cover the offending pathogen, and ideally we use an antibiotic that's the most potent for what's causing the disease, and also narrower, causing less collateral damage. The main barriers to de-escalation, though, is number one, the ability to identify the etiological pathogen in pneumonia. I showed that in about 14% of the cases, you can culture out the bacteria. There's difficulty in diagnosing non-culturable pathogens like the atypical bacteria, for example, and also the timely diagnosis, because we actually need this information earlier in the course of the disease, particularly when they're critically ill, like in the ICU setting, for example. And the cultures are usually come out by about 48 to 72 hours later in the course of the treatment. So that's where we have now these rapid multiplex PCR platforms that are very widely available. And we have pneumonia panels. And here I show an example of one, a film array. And you can see here the targets that it has. It has the targets for the agents of communicable pneumonia, including strep pneumo, H. flu, the atypical bacteria, the agents of hospital-acquired pneumonia, Staph aureus, the gram-negatives, including Pseudomonas acinetobacter. It can identify the viruses that cause pneumonia as well. And then the resistance genes. So you get information about whether there's a more resistant pathogen right away as well. CTXM is the gene for ESBL. Most of these other ones you see here are carbapenem resistance genes. The MEC gene is the MRSA gene. And all of this can be done in about 60 to 90 minutes after sputum submission and going into the PCR machine. And you can get the result oftentimes within an hour or two after the pneumonia diagnosis. This particular platform also gives you a semi-quantitative read, meaning the amount of the organism, bacteria that's in the sample, and there's a correlation with growth in culture. So 10 to the 7th would be 3 plus, 10 to the 6th would be 2 plus. This is another example of another PCR panel that's available around the world. This is called the hospitalized pneumonia panel, is what this one's called. This one's focusing more on just HAP and VAP, as you can see here by the targets. It does pick up the atypical bacteria as well. Not shown in this table is also picks up pneumocystis for AIDS patients. The runtime is a little bit longer for this particular HPN panel at 5 hours. And it's basically meant for nosocomial pneumonias, particularly people undergoing BALs. It does have a little bit more resistance genes detections, particularly for the gram-negative bacteria. But this is just kind of examples of these multiplex PCRs. We were one of the test sites for the film array, the one on the left-hand side that I showed you earlier. And so we published on our experience with this. And during the study period, when we were one of the test sites for it, what we found was that actually in over half the cases shown in the purple here, our standard cultures didn't grow anything. But when we ran the PCR on it, we actually figured out what was causing the pathogen in that sputum sample in a lot of the cases. So, for example, in 32% of the subjects, we found bacteria. And in 21% of the subjects, we found that it was actually a virus. And these are all specifically in the sputum cultures that either didn't grow anything or just had normal flora. What was particularly helpful in regards to bacteria that didn't grow on standard culture. And there's, by the way, many reasons why the bacteria may not have grown. Probably the most likely reason is that they already got antibiotics prior to the sputum sample collection. So it was just inhibiting the growth of the bacteria. Another possible reason is that the growth, the sample wasn't sufficient enough for us to grow the bacteria, wasn't adequate enough for us to grow the bacteria. But anyways, we found it particularly helpful in identifying patients with strep pneumo and H flu when we didn't grow anything, because particularly these two bacteria are very, very fastidious and very sensitive to pre-treatment with antibiotics, particularly by the time they leave the emergency room, they already got some sort of antibiotics already. But other bacteria were also PCR'd out that we didn't recover in culture, including Staph aureus and gram-negatives too, including Enterobacteriaceae and some of the beta-hemostreptococci. One patient had Legionella. And we did this study on both community-acquired pneumonia as well as hospital-acquired pneumonia. The PCR did not miss a pathogen that was identified by culture. There have been many other studies looking at this as well. And overall, what these studies have showed with these multiplex PCRs is that with BAL samples is quite highly sensitive, quite highly specific for the bacteria in the panels, 96% sensitivity, 98% specific, and good quality expectorate sputum, actually very similar numbers as well. So you can be very confident that if the pathogen isn't identified, then it's not present, assuming that the sputum quality is good. And it may detect pathogens that aren't identified by standard culture, particularly the ones that were already pre-treated with antibiotics already. After that study that I showed you, we embarked upon another prospective study. We elicited a grant to do this study where between the years 2021 through 2024, we prospectively enrolled patients getting the multiplex PCR. And our purpose of the study was to see specifically what kind of interventions could you do once you had the PCR result. And this, of course, involved the antibiotic stewardship team. All the results were sent to our stewardship team that then gave the primary team the recommendations. And we presented the results of our study in Los Angeles recently, in ID Week in Los Angeles recently. So this is the characteristics of the patients we enrolled in the trial. About half the patients had community-acquired pneumonia, and then nosocomial pneumonia was seen in probably equally split between VAP and HAP. About half the patients were in the ICU, the other half were on the floors. The samples that were obtained was BAL samples, expectorate sputum, trach aspirates. In this study, about 62% of the enrolled patients actually had no growth on culture, but of these, almost half of them we could actually figure out the pathogen by PCR. And here is the table showing what we identified in the study. This study, because it was ran between years 2021 through 2024, spanned the COVID pandemic. And so we actually could get a glimpse of what kind of bacteria we were able to identify when somebody had COVID, shown in the bottom table here. About half the patients with COVID either came in with a bacteria or developed a bacterial infection sometime during their stay, with the most common bacteria being isolated was Staph aureus MSSA here. But the most gram-negative Pseudomonas is the most commonly seen one. This, however, wasn't the reason for the study. The reason for the study was to specifically look at what kind of interventions can we do and in what time period. So here we can see that here's this on the left-hand side of the x-axis here is when we obtained the sputum sample. The PCR detection had a mean of about 2.9 hours after sample submission, sputum sample submission. And that the antibiotic modification was done at 6 hours after sample submission. This modification was done in 84% of the patients enrolled in the study. Again, our stewardship team reached out to the primary team in the ICU on the floor to give the recommendations. 86% of these resulted in de-escalation of the empiric antibiotics. The culture growth was on average, on mean, about 48 hours later, and then sensitivity was done about hour 90 afterwards. We also looked at specifically what kind of interventions being done. And so shown here in the numbers, these are not percentages, these are N numbers or specific cases. So in 5 cases, they did not initiate antibiotics because of negative PCRs. Atypical coverage de-escalation was done in 36 cases. Pseudomonas de-escalation was done in 69 cases. Escalation was done in 11. MRSA de-escalation 74. Escalation was done in 7. In carbapenem, there was more escalation by the detection of ESBLs, and they were non-ESBL coverage primarily in this case. So we were able to quantify the types of modifications that are being done in this study. There have been other studies that have been run on the multiplex PCRs. I show here one that was done in Mayo Clinic in Rochester, Minnesota. This study was done between years 2020 and 2022. These are all in adults with sputum or tracheoscretions or BAL, and they're randomized to either multiplex PCR or conventional cultures. And similar to our study, the results are reviewed by the antibiotic stewardship team, and then recommendations are given. So here are the results. What they found was that there were significant improvements or shortened times to antibiotic escalations in gram-positive and gram-negative bacteria. They also found significant improvements or shortened times to de-escalation for gram-positive bacteria, particularly seen in MRSA, meaning that they could discontinue drugs like vancomycin in a significant sooner time period when you got the PCR, and no MRSA was being PCR'd out. In another study, this study was done in the academic healthcare system, NYU, between years 2022 through 2023. They were looking at how helpful is a negative PCR and a negative culture in regards to your interventions. And so they had labeled 2 groups, ATDW, which in the ATDW group, if you had negative PCRs and sputum cultures, antibiotics withheld. In the ATC group, antibiotics were continued. And what they found was that in the ATDW, there was shorter antibiotic duration. That's to be expected since that's the group where they withheld antibiotics, right? So they had shorter anti-pseudomonal usage, shorter anti-MRSA antibiotic usage, shorter ceftriaxone and amsulbactam usage. However, what they also showed was that in the ATDW group where they withheld antibiotics, there was actually lower in-hospital mortality and lower incidence of kidney injury shown here. So there's other benefits for discontinuing antibiotics once the PCR and conventional culture was negative compared to just continuing antibiotics. So other beneficial outcomes measures. The AKI was probably due to the shortened vancomycin usage in this study. Lastly, I show here a cost effectiveness study. This is a sub-analysis on the multi-center study called the INHALE WP3 multi-center randomized controls trial. This trial was done in the United Kingdom at 14 sites between years 2019 through 2021, where in their ICU with HAP and VAP, they used PCR, multiplex PCR versus standard of care cultures. And what they found was that overall there was lower ICU costs when you used PCR in the intervention group, the PCR guided group. The average cost was looking at US dollars, $54,000 for standard of care versus $43,000 for the PCR intervention group. And a lot of this is driven by lengths of stays. So about $10,000 difference between the PCR and the standard culture group. So from a stewardship standpoint, the PCR guided therapy was both less costly and more effective than the routine patient management group. And so in the clinical applications here, I think what's important with these newer rapid multiplex PCRs is that we integrate them as part of your stewardship teams who can act upon the results and make recommendations. I think every single study has shown, though, that if the results are just shown in the computer system with no intervention upon it by any sort of a stewardship team, not a whole lot is going to be accomplished. So in our micro lab, what happens is that our micro lab alerts our stewardship team when they receive a request for the PCR to be run. The stewardship team then reviews the case to see if it's a good case to be done on. So number one, they want to make sure that they do have pneumonia and it's not some, CHF, for example. And number two, they also want to make sure the sample is good. And number three, that the team is willing to act upon the rapid results and not say something like, well, I'm just going to continue the standard care regardless of the results. Obviously, there's no point in doing PCR in that setting. It would be a waste of time. Then the results can be sent directly to the stewardship teams, and then who can give real-time recommendations. And we use it in any patients that's admitted, whether it be ICU patients or a floor patient. I think other centers are sort of stepwise using it in more severe patients, maybe a step down in ICU type settings. And you can create algorithms too, based on the results. So I'm going to show some examples shown here, and this is not necessarily the algorithm that you'll use, but just an example of ones that can be developed. So for community pneumonia, for example, here in the United States, we started the beta-lactam plus something very typical is like a macrolide tetracycline. You use the multiplex PCR panel, you get the results in about 60 to 90 minutes. If there's no atypicals, then we can discontinue the atypical covers, the macrolide or the tetracycline. If you do PCR atypical, then you can discontinue the beta-lactam. If there's a virus, then with viruses, really the only one that we can treat at the moment besides COVID-19 is influenza. You can then use oseltamivir if you did not know otherwise the patient had influenza and pneumonia. For nosocomial pneumonias and nursing home pneumonias, this is much more complex because the microbiology for this is going to be much more wide and varying with much higher prevalences of multi-drug resistant bacteria. However, again, a sample algorithm could be like this. So you start with an anti-pseudomonal antibiotic, a beta-lactam, plus an MRSA antibiotic. To start with, you run the PCR panel in 69 minutes, you get the results. If there's no MRSA, you can discontinue the MRSA antibiotic. If there's no Pseudomonas acinetobacter or any resistance genes that's detected, you can de-escalate from the Pseudomonas drug into maybe a cephalosporin, a third-gen cephalosporin, for example. If you do PCR Pseudomonas, here's a little bit tricky because the Pseudomonas resistances are chromosomal, so you cannot include that in a PCR panel because they'll always PCR it out. So we have to use clinical judgment here about whether they might have a more drug-resistant Pseudomonas or not. So do they have a recent history of drug-resistant Pseudomonas by recent cultures? Do they have risk factors for drug resistance, maybe recent antibiotic exposure, maybe a nursing home resident? If the answer is yes, you might want to escalate with Pseudomonas therapy. Examples of escalation would be drugs like ceftolozane, maybe ceftazidime, or maybe cefidoracol, the cephalosporin. If there isn't any such risk factors, you can continue the anti-Pseudomonas antibiotic. Maybe you can discontinue the MRSA drug if there's no MRSA. If Acinetobacter is PCR'd out, this is the other problematic pathogen that we have. Again, same protocol here with Pseudomonas. Clinically, you got to decide whether there's any risk factors for drug resistance or not. Any recent cultures, any antibiotic exposures recently, nursing home resident perhaps. If there is, you may want to escalate. Acinetobacter, multi-drug resistant Acinetobacter is very, very difficult to treat. We have to use very high-level drugs like the cephalosporin, like cefidoracol. There's another drug called durlobactam, sulbactam we could potentially use. Maybe some of the second-generation tetracyclines can be added while sensitivities are pending. If there isn't, then maybe use carbapenem. Most infectious disease doctors add high-dose sulbactam. That's going to be unison to that. If you get a KPC that's PCR'd out, you want to use an antibiotic that covers KPC. Ceftazidime is a common one. Meropenem-vibarbactam is another one. If there's a metallo-beta-lactamase, which is unfortunately becoming much more prevalent around the world, it sort of started in the Indian subcontinent, but you actually see this really bad carbapenemase now spreading across the world, including the US now. You want to change something that covers this highly difficult to treat carbapenemase. Again, Cidofovir cephalosporin, like cefiricol, or a newer drug that came out was azetrina, maybe Bactam. So this is just a sample algorithm that can be developed for HAP and VAP, not necessarily the one that you'll use in your institution, but just to show you that it can be done. I'm gonna end the talk with some sample cases from our hospital that were seen recently. The first case here is a 44-year-old woman with diabetes. She came to the emergency room for a week of cough, shortness of breath, fever, and then she declined in the past day. She suddenly felt worse in the past day. While in the ER, her O2 was 70%. On Romer, she needed high flow nasal cannula, which rapidly escalated to BiPAP, and she was intubated in the ER. She was hypotensive, and then placed on 3 vasopressors immediately. Her blood work showed a white count of 2.6 with 22% bands. You can see that on her EPG was very acidemic. Her nasopharyngeal influenza, RSV, and COVID PCR was negative. This is her chest X-ray. You can see multifocal airspace opacity. Some of them kind of look mass-like. Here's her CT scan showing the multifocal infiltrates. The ICU started vanco, cefepime, azithromycin, and even started tuberculosis drugs, I think mainly because of the mass-like lesions you see here. She's on 7 different antibiotics. She went to renal failure. Creatinine went to 2.6. Her blood cultures were 2 out of 4 GPCs and clusters within 24 hours. When we came to see the patient in ID the next day, we sent the sputum for PCR testing. The gram stain at this point in time was just showing GPCs and GPCs. Here's the PCR panel. So you can see that detected influenza and Staph aureus. And this Staph aureus was MSSA. There was no methicillin resistance gene detected. So what she had, and the blood culture PCR was also MSSA as well. So what she had was the very textbook and classical severe influenza pneumonia with a superinfection by Staph aureus. All those cases that I showed you earlier in the co-infections, this is what she had. So we had recommended that she change, this is hospital day 1. We had recommended the antibiotic be changed to a semi-synthetic penicillin, oxacillin, which is our best antibiotic for Staph aureus, and add oseltamivir. She was not on any influenza treatment because, again, her nasopharyngeal swab was negative. This actually, as you might imagine, was initially met with some resistance by the ICU team because she was so ill on 3 pressors. And the normal practice at this setting was just keep broad spectrum antibiotics on board for the next 2 to 3 days. And that's just the practice, right? But here we have to figure out what's going on hospital day 1. And so, so this kind of had to education and convince the ICU team that we do the broad spectrum antibiotics when we don't really know what's going on. But if you do know what's going on, you can then change them to the best therapy, even if it's on day of admission, hospital day 1. And she was finally changed over this, and she actually did pretty well afterwards. She got extubated within 12 hours after that. So in this case, the novel practice points was that the optimal antibiotic for MSSA was started about 2 days earlier in a critically ill patient than otherwise would have been via conventional methods. The viral pneumonia was not recognized by the traditional nasopharyngeal swab, which has a lower sensitivities, and oseltamivir would not have been otherwise started. As I showed you in the H1N1 studies, there's a mortality benefit even after 48 hours of very severe influenza pneumonia. Next case, 67-year-old woman with cerebral palsy on a chronic trach and vent with a G-tube, admitted from a skilled nursing facility for hypotension and hypoxia. She was had a very high temperature, 42.5, pulse was 150, her systolic blood pressure was 80. She was admitted to ICU for septic shock with a nursing home pneumonia. This was her imaging studies. The ICU chose to start her on meropenem plus amikacin as a double gram negative coverage. We did the PCR panel on her sputum, shown here. Acinetobacter, Pseudomonas, and then some other gram negatives like Proteus and Serratia. The KPC gene was detected. This is the carbapenemase gene that's most common in the United States. Remember, she's on meropenem. Amikacin, by the way, can cover drug-resistant gram negatives, but it's not that great for the lungs because of limited penetration into the lung tissue. This is ultimately what the cultures grew out. They actually show the same pathogens, but you can see all of them were carbapenem resistant. After the PCR panel, we changed her to the Cidofovir cephalosporin cefiricol, which all of these bacteria ultimately were susceptible to. And the novel practice point here was that we had immediate data on extensively drug-resistant pathogens leading to antibiotic coverage that, in this case, honestly, probably wouldn't have occurred until probably day 4 to 6 in this critically ill patient. She was in septic shock, and that's where the mortality benefit is seen in covering as soon as possible, using the right antibiotic as soon as possible. We also initiated early contact isolation for this extensively drug-resistant pathogen. And keep in mind that her initial empiric coverage did not cover any of the offending pathogens in this case. The last sample case here, 54-year-old man admitted for fever, cough, and myalgias and headache. He was mildly confused for 3 days. He was admitted with this diagnosis of communicable pneumonia. Here are the chest imaging studies. We did the sputum rapid multiplex PCR, and it was positive for Legionella pneumophila on hospital day 1. So we discontinued the cephalosporin antibiotic. It was only on the macrolide. The urine Legionella antigen, which we do in-house, and we can actually get that back pretty quickly, was negative. On follow-up, this is the chest x-ray. Patient was feeling very well, improved on just the macrolide itself. We had extended the macrolide course for 2 weeks. Typically, people give macrolides for about 5 days of using azithromycin, but with Legionella, we tend to treat a little bit longer. So the novel practice points here was that we achieved a very rapid Legionella diagnosis with early de-escalation, discharge, and appropriate therapy. Probably would have given 5 days of therapy, which may not have been enough for Legionella if we didn't make this diagnosis. And our standard ways of diagnosing Legionella here was negative, the urine antigen test. So in summary, I show here an image of the series that we have in the United States, and I'm sure you have it in Canada as well, which is Star Trek. Star Trek, of course, occurs many years in the future. In Star Trek, if you have an illness, you just run this machine that you see here, a tricorder, and it tells you what you have, the diagnosis, and then you give the appropriate therapy right away, and then in mere minutes. Ideally, particularly in infectious diseases, this is what we want our diagnostics to be at, but we're not at that stage yet. But with these multiplex PCR, we're getting there, So it's a major medical diagnostic advancement for pneumonia management and antibiotic stewardship. It really increases our ability to diagnose pathogens in pneumonia, and increases our ability to diagnose viral pneumonias and the co-infections of virus plus bacteria, which portends a more severe infection. Subsequently, we can then rapidly optimize and de-escalate antibiotics, even on the day of pneumonia diagnosis, including on the day of admission, as I showed in the examples. And this is going to be a big paradigm shift and a change in practice of our broad spectrum empiric antibiotic usage in pneumonia, because that's what's currently being recommended by our practice guidelines. But that's, our guidelines are written when these types of rapid diagnostics are not commonly used just yet. In other words, we don't always have to keep on using atypical coverage for communicable pneumonia or MRSA pseudomonas coverage for HAP and VAP if it's not there. And the studies have shown a significant improvements in time to escalation and de-escalation, decreased days of antibiotic therapy, mortality and adverse side effects, and cost savings in antibiotic stewardship realm. So that's the end of my lecture. I can take any questions if there are any in the time remaining.
Thank you very much, Dr. Jeng. I know we're coming up to 1 o'clock and I want to be respectful of all of your time. I don't have any questions right now. Maybe we'll wait a couple seconds. If not, Jen is going to be putting my email in the chat for all of you. If you have questions you'd like to ask or just reach out for more information, please feel free to do so. And there it is. So you'll have that now. And we'll give it maybe a couple more seconds, and then if there's nothing, we can wrap it up there. Oh, there we go. All right, we have time for one question. Hi, how successful is stopping the atypical coverage given that adding azithromycin significantly lowers 30-day and 90-day all-cause mortality for CAP?
So the question is, will we still discontinue the macrolide with pneumonia when studies have shown maybe some benefit for continuing the macrolide? I think what you're referencing is maybe some of this theory that a macrolide has anti-inflammatory effects. I think when you look around the world, the macrolide is not standard of care. It's actually, I think, done in maybe the Americas, here in the United States, maybe in Canada as well. I think that the data on that is there's studies showing some benefit of the macrolide, but you can come up with studies that also show no benefit as well. And again, when you go around the world, like Asia and other countries, they don't use macrolide at all, even for ICU level cases of pneumonia. And I think the benefit, the studies that do show benefit, it's only in strep pneumonia. Again, it's felt to be due to maybe some anti-inflammatory effects. I guess if that's your practice and you do have strep pneumonia from the PCR and you want to continue, you can do that. We don't do that here in our institution. We stop the macrolide because the feeling from our assessment of all the literature is that it's probably not beneficial, and the results are mixed. But if that's your practice, then of course, obviously, you can still do that if you believe that that's going to offer some anti-inflammatory benefit.
We do have some more questions. From Dr. Bertozzi, for outpatients, depending on how sick they are, when might you order a PCR to potentially prevent a hospitalization in a patient showing early deterioration or high risk for deterioration? Thank you for the presentation.
So, I think most of the studies with these multiplex PCR panels are done in the inpatient type setting, not in the outpatient type setting. I think the trying, and I think in the setting that I'm wondering if the setting that you're talking about is maybe the emergency room, perhaps. Um, and in the emergency room, if you're going to keep the patient there anyhow while running the results, then I think it may have a role. I think in most emergency rooms, I think you're trying to triage them um, quickly, right? So, for example, if you're going to discharge them, I'm not sure you would run a PCR type testing, which is going to take 69 minutes if you're already going to discharge them because they're not that severe. You can probably still do that in a clinical type setting. If you're going to admit them, though, and there are clinical trials published, that is, from the ER setting where they did use the multiplex PCR setting, but these are all patients that were going to be admitted actually, so that you don't have to keep the patient in the emergency room. You can probably send them upstairs. You could send the PCR away, send them upstairs or wherever they're going, and then they can act upon it. I think that's where we're going to probably see most of the data coming from, and the benefits from a cost effectiveness standpoint from that setting. I don't think in people being discharged home, we have a good grasp, I think, on the cost effectiveness of that just yet.
Do you have time for one more, Dr. Jeng? Is that all right?
Yeah.
Great. Can you comment on the use of tracheal aspirate versus bowel samples for PCR testing?
Right. So the question is about tracheal aspirates versus BAL, and the BAL is going to be the better sample because the BAL should not pick up tracheal colonization. I think the tracheal aspirates, a better way to do it might be to do like a mini BAL, which is like when you stick a tube down the trach site, so it's below the actual trach itself, and then maybe into one of the major bronchi, and then you instill saline and suck it back. So that's called a mini BAL, and it can be done without a bronchoscopy. That's going to be better. The worry, of course, with just doing if you just have, for example, sputum sitting on trachea and then you just collect that sample is that you may pick up colonizers, and it may be more difficult to distinguish a colonizer from a true pathogen by PCR type technology because it's going to identify all of them. It will give you a semi-quantitative amount, but if you can get a lower sample, that's always going to be better.
Wonderful. I think that's it for questions for now. Thank you very much, Dr. Jeng, and thank you all for being here today with us. We appreciate your time and have a lovely day.
Thank you so much.